Hello, can anybody hear me? Okay, so I'm going to get started. So my name is Trent Settles. I'm a P4 pharmacy student at Auburn, and I'm going to do a talk about neonatal bacterial sepsis and meningitis. A brief definition of sepsis is symptoms and signs of systemic infection caused by a pathogen in the blood, and then meningitis is inflamed meninges typically caused by a pathogen in the central nervous system. So neonates have an immature immune system, and this increases the risk of sepsis and meningitis from bacteria and different infections. So they have a decreased functions of complement cells, granulocytes, humoral cells, macrophages, and T cell functions. They also have immature skin, and this can be compromised from drawing labs and performing different procedures. So early onset sepsis is within 72 hours of birth, and late onset sepsis is after 72 hours of birth. So first, we'll talk about early onset sepsis. It may look a little bit like respiratory distress or apnea of prematurity. So you should look at the neonatal and mother's history for risk factors. This is a chart that shows all of the risk factors that you would typically look at, and we're going to talk about a few of these. So if it is indicated, blood and cerebral spinal fluid culture should be obtained, and a CBC with DIF may help with diagnosis. So like abnormal white blood cells, bands, segmented neutrophils, and platelets. They can jointly be used to identify early onset sepsis. And something else that we use to identify this is something called the immature to total neutrophil count. And so basically what that is it takes the immature neutrophils like the band cells, myelocytes, metamyelocytes, and then they divide it by the total number of neutrophils, which includes segs. And so if this number is above 0.2, that indicates that over 20% of total neutrophils are immature. And this occurs because the bone marrow is pushing out the immature cells to help fight infection. And so this would make you think that this is an increased risk of having sepsis. Another thing is neonates weighing greater than or equal to 2 kilograms with a low absolute neutrophil count increases their risk of having early onset sepsis. Another thing is elevated CRP, which indicates infection. You don't want to use this value within the first few hours of birth. Another thing is 2 normal CRP values within the first 48 hours of life is a negative predictor of them having an infection. Another thing is elevated procalcitonin. You can look at this to also help aid your idea that it might be an infection, but you don't want to use this alone as an indicator. And PCT or procalcitonin typically is increased within the first 2 to 4 hours of infection, and it peaks around 6 to 12 hours. So common pathogens that you can see in neonatal early onset sepsis, first is group B strep or strep A galactiae, and then E. coli. For term neonates, group B strep is more common than E. coli. For treatment, so you want to use empiric antibiotic treatment if you suspect early onset sepsis. And so you want to use ampicillin plus gentamicin. So dosing for these varies by weight and or age, and then each place that you work has their own dosing protocols for neonates and pediatrics. For monitoring, for aminoglycosides, you're going to monitor trough concentrations, you're going to monitor renal function, and also for ototoxicity. Another option you can use instead of aminoglycosides is a cephalosporin called cefotaxime, and this can be used in empiric therapy as well, but it has increased resistance compared with aminoglycosides and also increased risk of invasive fungal infections. So you should reserve cefotaxime for meningitis. Something else that they've started doing in early onset sepsis treatment is they started giving the mother intrapartum antibiotic prophylaxis, or IAP. So the reason they do this is because group B strep is the leading cause of newborn infections, and the primary risk factor for the neonate to get group B strep is the colonization of the mother's genitourinary or GI tracts. So what they do is they screen the mother for group B strep, somewhere between 36 and 37 weeks gestation. Since they've started doing this, it has reduced group B strep, early onset sepsis, by greater than 80%. So in the 90s, it was about 1.8 per 1,000 live births. And now in 2015, it's 0.23 cases per 1,000 live births. So it has helped a lot. And the IV penicillin is the agent of choice. Okay, so the first thing we're going to talk about is neonates less than 37 weeks gestation. And so empiric therapy is warranted if neonate has one or more of the following. So chorioamnionitis, if the mother had inadequate IAP, if it was indicated, and then prolonged premature rupture of membranes. Blood culture should be obtained before initiating empiric therapy, and then white blood cell count with differential should be drawn between 6 to 12 hours of age. If there's no growth on the blood culture after 48 hours and the labs are normal for their gestational age, you may discontinue the empiric antibiotics. If the blood culture is positive, you want to continue the empiric antibiotics and then also obtain a cerebrospinal fluid culture via lumbar puncture. Further, you want to continue empiric antibiotics if the neonate doesn't look well, the labs are abnormal, and then also if the blood culture is negative and the mom had antibiotics during labor. For neonates greater than or equal to 37 weeks gestation, if the mother was diagnosed with chorioamnionitis, empiric antibiotics are warranted after we get a blood culture, and then the treatment is the same as the less than 37 weeks gestation. So if the mother had inadequate IAP when indicated or prolonged premature rupture of membranes, we'll want to get a white blood cell with differential alone, or you can get this along with a CRP. If the labs are abnormal, we'll obtain a blood culture, and then if that blood culture has growth, we'll start antibiotics. If the neonate appears well, blood culture has no growth, and the labs are normal, that baby may be discharged at that time. For cultures, once the pathogen is identified, we will just de-escalate therapy depending on which pathogen. And looking at this chart, basically for sepsis duration, it's anywhere between 7 to 10 to 14 days. For meningitis treatment duration, it's 14 to 21 days. And that's depending on which pathogen is identified. Next, we'll talk about late onset or nosocomial infections. So it looks a lot like early onset sepsis. We're also going to get blood cultures in these patients, and then also a urine culture. And then meningitis is more common with late onset compared with early onset. So we'll also get a CBC with differential, and we'll assess it similar to early onset. And then looking at this is the cerebrospinal fluid, how you'll look at that. So normal versus bacterial. If the white blood cells are between like 1,000 to 5,000 versus like 0 to 25, that would be indicative. Also, if the glucose to serum ratio is less than 60% instead of being around 70 to 80. And then if the proteins are above 170, so if they're like in the 300, 400, 500s, that would be indicative of infection. Common pathogens are similar to early onset with the addition to coagulase negative staph and also Enterobacter. And then Candida may also be prevalent. It depends on at your specific institutions. For the treatment, we'll also do empiric treatment. And with late onset sepsis, we'll do vancomycin plus an aminoglycoside. Also, AMP-B may be used if fungal infections are common. And then we'll also de-escalate therapy once a pathogen susceptibility is known. For monitoring, we'll look at renal function and also troughs for vancomycin and the aminoglycoside, as well as ototoxicity. So in conclusion, immediate empiric antibiotics decrease the risk of an adverse patient outcome. And it's important to know what common pathogens could possibly be present based on the type of infection and local patterns. And as always, de-escalating antibiotics is very important because it reduces side effects and future severe infections. Thank you.